last part of the talk is focused on presenting the solutions that we have, and we will briefly see a paper that we presented this year on AME conference. So first of all, World Health Organizations predicts that global healthcare workforce shortage will reach about 13 million in coming decades. Second, we see that in Russia there is a pretty big shortage of medical healthcare professionals. I tried to find the same stats for Armenia, but I couldn't. But I believe that this situation is the situation is the same in all parts of the world. Moreover, there is evidence showing that medical errors actually are a pretty big problem in healthcare. You see a report from Johns Hopkins University who suggests that medical errors is pretty big source of death in the United States. Even Ministry of Healthcare of Russia said that yearly they register 70,000 cases of problems caused by mistakes that doctors make. And actually the problem is pretty big because there are even Telegram chats where people speak with each other, where usually doctor will just take a photo of the screen and ask his colleagues some question, and then they will start speaking about it, discussing it, and make some suggestions. And nobody knows who are those people in chats speaking about some cases. And actually, I'm not sure what would I prefer, whether my doctor asking about my case to some strangers on Telegram or using artificial intelligence. So the idea is that we can help doctors with artificial intelligence. There are cases where artificial intelligence in healthcare is useful. And main reasons why it's better is AI is objective and stable. We can parallelize AI as much as we can, whereas we need to train doctors, and training a doctor takes a lot of time and resources. Actually, there are types of data that can take a lot of time for doctor to analyze, like Holter ECG monitoring that can be done for a week. And can you imagine a doctor sitting for several hours trying to find those minutes or two where there are some problems with heart? Next thing is that AI is actually cheaper. And actually, there are some specializations where even training a doctor would not lead to somebody who can do that, like reading histograms, reading cells on a microscope and understanding which kind of cell given cell is. It's actually a very, very hard task. And for some types of cells, there are just a couple of specialists in the world. Next, we will speak about dangers of AI in healthcare. So, first of all, when we are analyzing any instrumental recordings that are made of a body, in a lot of cases, the output may be vastly different. You can see that in this picture, evaluation of image reconstruction for CT, and you can see that actual quality of the picture and amount of noise is very different for various kinds of CT scanners and the modes of their work. Moreover, a lot of CT scans or any medical imaging devices can have a lot of artifacts. I just briefly listed all kinds of artifacts that we can see, and currently, not all medical imaging systems do find those kinds of artifacts, and those can be a source of error. Um, Another problem is that doctors can control type of CT scanning that is done and can control for parameters of the scan, whereas AI solutions do not do that, and that is another problem of using AI in healthcare. Another problem is that a lot of even commercial grade software that is made is trained for finding some kinds of pathologies for for given images, and usually you can't predict what will happen if some other kinds of pathology would be fed to the model. So uh, it's an engineering and product design problem, but still it's very important. Another problem is known thyroid cancer's epidemic in South Korea. At some moment, they started to test everybody for thyroid cancer, and as you can see, they started detecting more and more cases of thyroid cancer, whereas thyroid cancer mortality didn't decrease in any significant manner. So it means when we look at this graph, we see that a lot of people are getting treated, but all those treatments can be very harsh, very bad for health, and the idea is that when we increase quality of diagnostic methods, they can find cases that are not that malignant. So if we find more cases of cancer, we can treat more patients, whereas maybe a lot of those patients do not really need treatment. Another problem that we do not think about much is positive feedback loops that emerge when AI models that are constructed and using the AI models in healthcare practice, and then collecting some other data and training new models. All those loops can build some positive feedback loops that we are even not that aware of. So that is another problem, and the main problem is that we are still AI in healthcare is not used that much, and there may be unknowns that some problems that we are not even thinking about. So what I am talking about is that we need to test everything and be careful. So let me shortly tell about the solutions that we have, and one of the solutions that that we are testing this year. Basically, we are working on many different applications of AI in healthcare. One of those applications is analyzing Holter ECGs, which is very time-consuming and tedious task. We have a model which can detect neoplasms on mammograms. That is very important because breast cancer is a very dangerous disease, and we need to test. Regular testing is very important, and helping doctors to test and improving quality of testing is a very important task and can lead to decrease in mortality. We built another model that can detect pneumonia on CAT scans, including COVID-19. This model can find places in lungs that are pneumonia, and calculate amount of those regions and build some kind of report. One of the very important work that we did is detecting stroke on CAT scans, and actually this model, we tested this model, and it showed that it's better than 9 experienced radiologists out of 10. Another topic that we are working on is analyzing electronic health records. Whereas while analyzing medical images is a very wide field where a lot of researchers are working, we believe that analyzing electronic health records is still less popular field where we can do a lot of quality work science-wise. And another topic that we are working is using medical knowledge-based methods to improve the qualities of the models that we build. Next, I wanted to talk about a paper that we published on Artificial Intelligence in Medicine conference this year. The paper is available on arXiv, and the paper is focused on predicting clinical diagnosis given health records, and actually predicting a diagnosis from first visit of patient to a clinic. So the task is to, given EHR data for initial visit, figure out 3 most probable diagnoses that given patients have. How do electronic health records look in our relational database management systems? It can be thousands of tables, tens of thousands of fields, and the biggest problem is that format of those records can change through years. So actually, it's a pretty big problem to try to normalize that data. And even if you would like to normalize blood analysis or some other analysis, it will take a lot of time that usually no scientific lab have. And we actually tried that, but basically it's a lot of work, and that road didn't lead us to any good solution. Another solution that we tried is to take all those tens of thousands of fields and convert that to one uniform representation. We read papers where this approach worked, but maybe our data was more noisy. Maybe for some other reasons, this solution didn't work for us again. So, and we have one of our researchers, after many hours of looking at medical information stored in EHR records, he proposed Grievous Hypothesis, and the hypothesis is that all the crucial information is stored in 1 or 2 fields. It's a Pareto principle applied to EHR, and the idea is that doctors just use some fields to store any data that may be useful to some other doctor. And in this situation, we don't really need to use all the information stored in EHR. Doctor actually did some work for us by collecting all the required information in some other field, some one or two important fields. And what we did, we took the data and just concatenated it as a string and decided to build a BERT model using that string taken from EHR records. Our study was focused on 3 data sets. Some of those data sets were taken from commercial clinics. Some of those data sets were taken from government-based public clinics. Overall, it's about 1 million patients and more than and about 4 million visits, ranging from 2015 to 2019. And to our belief, it's one of the largest study in the world and the largest study for Russian. We tried several models. All of them were based on BERT, and basically applied them to the text that we collected from EHR. We did some modifications of BERT, and if you are interested, I offer to look at the paper as the changes are so, and as we don't have enough time to go into this. After we tried training those models, and the results that we got are presented here. What we are interested in is this column hit L3. It means that fraction of results that where we predict the correct diagnosis, when we allow a model to predict the 3 most probable diagnoses. So we obtained a solution which can do this in 70% of cases. And the solution predicted one of 265 possible diagnoses. We trained a model that can predict diagnosis with a coarser list of diagnoses. This is the last one, RUPL BERT 1K, and the quality is not as good as we see previously, but the 265 version is actually good enough to be used in practice. We conducted experiments where we took visits to other clinics. We asked experts to predict 3 most possible diagnoses given the information from EHR records. And those 2 experiments showed that our model actually can do this better than experts. And in one experiment, the difference was about 1%. In another experiment, difference was much bigger. And we think that it's because of the difference in data. That's basically it. And one important thing that I wanted to talk about is that actually a model trained on one clinic worked pretty good on data from another clinic. It was very surprising for us, as flows of patients, idiosyncratic names of diseases or analysis can change from clinic to clinic. But our experiment showed that it works pretty good. So that's basically it. If you have any questions, I would be glad to answer. And and here is my email addresses for any other inquiries that you guys may have.
Thank you very much, Manvel. And Hrant has a question. Hrant, would you like to unmute and ask it?
Yes. So first question, I actually have many. For Electronic health records. What do you do with the tables? I understand that you have text in Russian, right? That's the clinical notes.
Yeah.
But then you want to pass all of it to BERT. So do you ignore the tables because of this hypothesis, or or you found a way to encode it in text?
Yeah, so I would say that Grievous hypothesis is as important and wasn't Greek's one. And so what we do, so we found two fields from those 10,000s of fields where doctors store all important information. So, and our belief is that doctors are lazy like everybody else, and that they will store all the information that is important in one field. So, his friend, his fellow doctor, wouldn't look in 10,000 other places for the important information. So, the answer is that we find a couple of fields and concatenate them as a text, and that's it.
Okay. Uh, so as we do not have other questions, I will ask you more technical questions. When you said 265
Yeah.
diseases, is that somehow connected to the ICD codes, or it's
Yeah.
something?
Yeah, actually, that's ICT codes. We took all ICD codes for all the diseases, calculated the proportion of those ICD codes in a stream, and took 265 diagnoses that amount to 95% of all the diagnoses. So we have actually 265 diagnoses and one diagnosis that takes all the rest of diagnoses.
Oh, okay. Something else.
Yeah, yeah,
Interesting. We had similar work based on the publicly available dataset, Mimic 3, right?
yeah.
And we were afraid of doing this, so we grouped them into 25 categories. One of our co-authors had medical experience before doing machine learning, so he knew how to group this, or I really didn't understand what he did, but we ended up with 25 labels only.
So yeah, we grouped them using ICD codes tree. So it's actually ICD goes through to some level in the tree,
I see.
and uh, and our data is a little bigger than Mimic 3. So yeah, so we were able to train a model with much more labels, possible class labels.
And you do multi-class classification, right?
Yeah, so we predict 265 probabilities.
Okay. And I think one thing I was confused. You said that 25 to 30% F-score is good. In which applications it is good? I don't follow it. I think.
Yes, yeah. So we are actually launching this service in 3 different regions of Russia. And this service will be included in an interface that doctor is working with. And when the doctor is entering a possible diagnosis, he will be shown 3 diagnoses that the model predicts. And the idea is that this thing will focus attention of the doctor to the most important ones. Actually, we were thinking about some other uses. If the task is to improve the probability of finding out cases of cancer or cardiovascular diseases, we can show 3 most probable diagnoses that are cancerous. There are cancer or some kind of cancer, or 3 most important diagnoses that are cardiovascular disease or some other. But right now, what we see from our customers is and our clients is that they want a model that will help some doctors to not make mistakes, as mistakes are very dangerous in this case. So I saw another question. Sorry for interrupting.
I've also. Okay.
Yeah. Okay.
Do we have any other questions?
Yeah, there is one on Q&A, but you can go forward, and then I will read the question from Q&A.
I want to say thank you for a very interesting presentation. Just like to know if these systems are already in have found application in some hospitals or no.
This system is not used anywhere right now, but we are launching it in 3 regions. It means that all the hospitals, all the public hospitals in 3 big regions in Russia. And but unfortunately, I can't talk about that right now. But we will be speaking. We will publish some news about that when we will do that.
Did you consider the legal issues which may occur?
Yeah, actually, there are some legal.
Yeah, very big problem, that legal issues with AI, and so far there is a lot of unanswered questions there.
Yeah, it's a huge question, and actually, in some parts of Russia, there is using AI in healthcare is allowed in experimental cases, in experimental scenario. And the second thing is that this model will just help doctor. It wouldn't make any clinical decisions. And actually, the influence that this model will have is minuscule right now. In the future, we can think about more involvement in treatment case. But right now, the answer is this.
Okay, thank you.
Thank you. So the question is, how do you label data? Do you use the previous diagnosis? Maybe they change it and are not comparable to the temporary diagnostic methods. I mean, they might be different according to the progress of medicine. So what we did is we worked with visits of patients to clinics. And we took one first visit of a patient to clinic and took the diagnosis that doctor gave to those patients. And we used labels already contained in the EHR records. And the task is to predict the label that doctor gave to given patient at given visit, given the data there that we have in EHR.
Because as a next step of this question, in Mimic we had this problem that it was not possible to understand when the ICD code was put on the patient. So you have like time series of months, and there is some ICD code and you don't know when it was applied. So how much information the doctors had when they gave this diagnosis. So we had to take the whole data, the whole time series, and put a label, but it's not clear whether it was changed in the time or.
Yeah. So actually, what we did is we took diagnoses that they used to treat a patient. So we took a data from the first visit. And each visit contains a diagnosis that the doctor gave to the case. And we predicted the diagnosis that they will start treating the patient with after some time. So yeah, we didn't have this problem because every visit has a diagnosis attached to it.
I have a question.
Yes, please.
Looking forward to in the future, I was wondering. So the medical system, in my understanding, is a complex decision-making system. In terms of when we go to a doctor, it's not a simple threshold problem, and we have a diagnosis, and then there is a treatment, and everything is clear. There's a lot of uncertainty. There is a lot of bargaining, talking with the doctor about other options. Can I start the treatment later, and so on and so on. And as I understand, currently the research is more looking into sort of the building blocks, which obviously are important. But I was wondering, is there some research or thoughts on how this complexity of back and forth, including costs and uncertainties and all these layers, how is this going to get factored in?
Thanks for the question. So right now, what we are focusing on is helping doctors with diagnosis. And I agree with you that treatment process is very long, hard, and I showed cases where it is a very big problem. But right now, the work is mostly focused on diagnosis. There is some work focused on helping doctors with treatment in some cases where choosing treatment may be very hard, like cancer. But it's a question that we will work on in the future because it's actually a very hard problem. So,
let me ask you one more thing. Can you comment more about this Holter ECG project? So when you have a Holter ECG, it contains hundreds of thousands of heartbeats, right? And
yeah.
there are some ECG software that can automatically even detect the boundaries of heartbeats and separate individual heartbeats. And maybe you can do some classification on each individual heartbeat, but you can also do on series of heartbeats depending on the disease, probably, right?
Yeah.
Can you comment more on that? How do you do and what exactly you are trying to find?
Yeah, sure. So what doctors do, they take these hundreds of thousands of heartbeats, and they use a software that actually detects heartbeats and then clusterizes them, and then doctor classifies each heartbeat, and then software builds actually statistics showing that like how many heartbeats were normal, how many heartbeats had some problems. What we are doing here is helping doctors with those classification tasks, because even using this software, analyzing a single Holter ECG can take up to 3, 4, 5 hours, and it's actually a very tedious, time-consuming task. What we do here is we divide ECG recording, which has, if I'm not mistaken, 6 channels, and then divide it to heartbeats, and then we build a model that predicts some classes for each heartbeat, and then we output it as a file that can be loaded in any ECG analysis software and used. Actually, here we showed that this model is better than some of commercial grade software, and we are hoping to publish this paper this year.
That will be very interesting. I'm involved in one such project at Yerevan, and we realized that the inter-annotator agreement between doctors is so low sometimes.
Yeah, this is the problem that we face a lot of times, because actually there are studies that are easy to read, and in that cases, it takes only 5 minutes for the doctor to analyze and figure out some decision. But in some other cases, they don't agree at all, and we've seen that in this case in these experiments, because in some cases inter-doctor agreement was less than 50%, and average agreement rate was like 60%. I'm not sure about the numbers, so it showed that how heuristic doctors' work is, and it's it's a regular problem that we face. And actually in AI in healthcare, usually the problem is that you have a very limited amount of labels, and they are not very exact. And the task is to build a model that will work with those circumstances. In some other cases, reading mammogram, as shown here, is a very, very hard task. And people study several years to read them. And in many cases, doctors don't agree with each other. So those are hard those are pictures that are hard to analyze, whereas in this case, detecting pneumonia is like pretty not easy, but easier.
Okay, and one more question about ECGs. So, in our experience, when we have like several hundred holters from several hundred patients, but we have so many heartbeats from each patient, then it is usually very easy to overfeed on patient-specific features, right? Because you can recognize that this patient has this disease.
Yeah.
And it is known that the shape of the heartbeat is a good personal identification thing, so you can even identify the person using the ECG recording. So you have to be very careful to not overfeed on the patient-specific stuff. And the only solution we could find is to use very small networks. Like we used convolutional network with, I don't know, 500 parameters only. And it's interesting to know if you had this problem, although if you are doing heartbeat level annotations, that might be a less of a problem. In our case, it was like patient level annotation, but you want to predict from a single heartbeat. So all heartbeats from, so yeah, you get the question.
Yeah, I get it. So actually we had the same problem and find some other solutions that I can't speak about yet because we want to publish the paper. And yes, it was a big problem. And what we did is we used a larger data set, analyzed on heartbeat level, as you said, and actually it didn't help for many kinds of diseases because like we have a large data set of several hundred patients. One patient has some kind of disease like 10 heartbeats from the whole data set. So you can't build any model with that. So it was still a big problem.
Thank you.
So thank you.
Yeah,
So
there is another question in the Q&A.
Yeah, Grigor Nalbanyan is asking, what about interpretability issues? If the model predicts a disease, should there be just the most probable class or there should be some interpretation provided too? Yeah, that's actually a very good question. And that is a direction for improvement for this model. Because right now the predictions are not interpretable. It couldn't say why he chose given diagnosis. Still, it's practically useful, and we are actually launching a test use of this system in several clinics. But we are thinking about trying to interpret them. And we even tried some preliminary steps, but they didn't work as good as we wanted. Another question is what the doctors want the interpretation to be, because in a lot of cases, decision is made from like 100 words out of 1,000 words of EHR record. How would you do? How would you build an interpretation of that? Second question is, do doctors really want an interpretation? We, as researchers and data scientists, think that it's actually a pretty good problem, and it's a problem that we all want to solve. But do doctors actually need that? And would doctors look at interpretation more than once? Still, it's a big problem. Another thing is to distinguish between interpretability and explainability. where interpretability shows why a model chose something. Another problem is explaining some other things that may be important for doctor. So predicting, showing what other types of tests patient needs, for example. So actually, it's a pretty big problem that we are working on, but we still don't have a satisfiable solution. And there are many questions. And actually, in the literature, there are a lot of cases where people first build uninterpretable models and then build interpretable ones from them. But we are not sure that those models would be uh, would have as much of impact as our model has, because our model works with any kind of uh, databases, any kind of storage, and that's why it was chosen to be launched in several regions of Russia, because it is very, it can eat any kind of data, and it actually works in different, in data collected in different places, in different clinics, and that is one of the strongest moments of this model.
Thank you very much, Manvel, for the talk and for taking all this time to answer the questions. I hope you will be around in Slack. I think there might be others as well who would like to talk with you. Yeah, thank you once again. And we are off to an extended break because our next speaker unfortunately cannot make it today. So we will either reschedule his talk, but right now we don't have a talk, so we have an extended break. Meet you all at 14:30.
Thank you for having me. I will be glad to answer all the questions, and see you on panel discussion. Thank you very much.
Thank you.